No comment? How is farm going then? I feel like every block is the hardest block. Yeah, so I had a lot of people have messaged me about Dr. Babos and this block, and honestly, she's giving you. Well, okay, I have to be careful how I say this. She's giving you a lot of it you need, but a lot of it you don't need yet. Like, knowing what a drug is used for, that's really not that important right now. Like, the questions that you're going to see this year are going to be based on like the mechanism of action. Like, what happens if I give somebody a muscarinic agonist or an acetylcholinesterase inhibitor, and what receptors do those target? Um, Whereas, next year you need to know, like, how can I treat hypertension in a pregnant woman? Or, uh, you know, uh, what drugs do I give for a male with benign prostatic hyperplasia? Those are more second year questions. So, like, what you need to focus on right now is how do these drugs work, not necessarily what they're used for, unless it's something that she, ding dinged or hadn't read. Um, so don't get overwhelmed by all of that extra information. Um, because, I mean, I can say from last year, if you pay attention to every time she says, this will be on the test, or, like ding ding, woof woof, all of those, like she's telling you exactly what's on the exam. So all of this extra, like, blah blah about plants, tropobelladonna, yada yada, like you don't need to know all that stuff. If she starts shouting about this will be on the test, like you can trust her with that. Um, yeah, so hopefully that helps a little bit. All right. If I know the red ding dong robot, is that enough? Yes and no. Okay, so Dr. Weaver, she's more of a like, I'll just put like 5 out of 7 entire sentences on the slide in red, and as long as you know all of that, then you're fine. But Dr. Babos is more like, I'm going to put 1 or 2 words in red, and you need to know everything surrounding those words. So if a slide has like a small phrase in red, like you probably need to know everything surrounding that. Oh, yeah, that's fine. Yeah, but she is telling you what's on the exam, so I don't think there's going to be anything on there where you're like, oh, I didn't think we had to know this, or surprised, or anything like that. Okay, so we're going to start. Um, I decided to kind of go back to the beginning. I'm not going to spend as much time on it. Like, if you look in the first slide set, I had a bunch more practice questions, but I just thought, with the amount of people that have been messaging me, that, maybe some repetition over some of this more like introductory stuff would help things down the road kind of click more. Okay, so just bear with me while I kind of go through some of the same stuff again. Okay, so one of the questions that we had last year, and I've been watching her Blackboard recordings, and she did say that she's going to do it again. So she'll give you a schematic like this, and everything will be whited out, and you'll have like A, B, C, D, whatever, and the question will be like, what is released at A or what is released at B. So you need to make sure that you can draw out this schematic, okay? So in your somatic nervous system, you have acetylcholine released at the neuromuscular junction. In the parasympathetic nervous system, you have acetylcholine released onto your M1, M2, and M3 receptors. And then in the parasympathetic nervous system, you have norepinephrine released, which is going to activate alpha 1, alpha 2, beta 1, and beta 2. And then remember that on the postganglionic sympathetic fibers, you have these alpha 2 receptors, and those are going to act as autoreceptors to control the release of norepinephrine. So basically, they're acting as like a negative feedback mechanism to control your sympathetic outflow. The two that she's probably most likely to ask about in this question are going to be the fact that epinephrine is released from the adrenal medulla, or even though it's sympathetic in origin, the fact that acetylcholine is released from postganglionic sympathetics that synapse at your eccrine sweat glands and activate the N3 receptors. So starting place is making sure that you can do this from memory, and this is going to help you answer a lot of questions. Okay, so just for repetition, let's run through sympathetic versus parasympathetic. So your sympathetic side is your fight or flight side. So what do you want to do when you're about to run away? So you're going to have alpha 1 activation, which leads to mydriasis, so pupil dilation. Remember the A in mydriasis means dilation. You're also going to have reduced salivary flow and increased stroke volume and heart rate by activation of your beta 1 receptors. And then one of her ding dings is this right here. So on vascular smooth muscle, when you're activating your sympathetic nervous system, your alpha 1 receptors are innervated, but beta 2 is not. So beta 2 activation comes from release of epinephrine from the adrenal medulla. And then, okay, so if you're running away, you have reduced peristalsis and secretion because you don't want your stomach going crazy if you're trying to run away. Increase glycogenolysis to produce more glucose for energy to the body. And then also inhibition of bladder contraction. Or what you'll often see is inhibition of the detrusor muscle. So remember, the detrusor is the muscle of your bladder. And then another ding ding is the fact that when you activate the sympathetic nervous system, your beta 2 receptors are activated by epinephrine release from the adrenal medulla. And this leads to bronchodilation. So if you're running away, you want to make sure plenty of air is getting to your lungs. And on our parasympathetic side, this is our rest and digest side. So we're going to be salivating, lacrimating, urinating, defecating, and then also bradycardic, because our M2 receptors are activated on your heart to decrease the heart rate. And also meiosis, that's a big one. So constricted pupils and accommodation for near vision. And then her third ding ding was the fact that N3 receptors on vascular smooth muscle do not receive postganglionic parasympathetic innervation. Okay, let's keep going. I did have this in the last set, but I noticed that people were kind of hesitant to answer, so I just want to make sure that we understand this. So which pathway is going to result in bronchodilation? 1, 2, 3, or 4? Right. So remember, so epinephrine released from the adrenal medulla is going to activate beta 2 receptors on your lungs, leading to bronchodilation. So that is a very high yield point. M1s also are never activated right, unlike the beta 2, which can be activated on the vasculature. Yes, that is correct. So alpha 1 receptors are innervated, but beta 2 are not. However, beta 2 can be activated by the release of epinephrine from the adrenal medulla, whereas M3 receptors on the vasculature are not innervated by postganglionic parasympathetic fibers, so therefore they can be activated. So yeah, you're exactly right, and that is very important to know. Yeah. Okay. So the more you know this chart, so M3 can be activated, but not by an endogenous substance. So there was one drug that she talked about that can activate your M3 receptors. And we're going to get to that, but does anybody remember what we're talking about it? No? Okay. So pilocarpine. Do you remember talking about pilocarpine? Yeah, okay. We're going to go over this again. So we're going to get to pilocarpine. Yeah. So endogenous substance means something that is released inside. Yes. Yes, Cody. Something that is released inside of the body. So when we talk about epinephrine released from the adrenal medulla, that means endogenous. Whereas if we're giving a drug, then you're talking about exogenous. So exogenous administration of pilocarpine can lead to activation of M3 receptors. So M3, as far as my understanding, which is just based on what Dr. Babos said, is one of those things where it's there on the vasculature, but we're not really sure why, because nothing that's released endogenously activates it. Does that make sense? And you're right, so M3 receptors on your eccrine sweat glands are going to be activated by acetylcholine and cause sweating. And then also, you can look at this chart, you have M3 receptors in a lot of other places, but that's on the parasympathetic side. Yeah, so nitric oxide works by increasing cyclic GMP, I believe. Yeah, that sounds right. Okay. Well, Amy, hopefully, the more stuff we go over, maybe it'll start. Oh, are you talking about nitric oxide? Regardless, hopefully the farther I go, this stuff is gonna just start making more and more sense. Okay, so on your parasympathetic side, remember those are your muscarinic receptors. So remember M1 in your brain, M2 in your heart, and M3 everywhere else. And I don't mean everywhere, I mean everywhere as in what's listed here. And then also, you guys said that you are familiar with the KISS and KICK mnemonic. So remember, and I'll jump ahead real quick. So KICK, Q-I-Q. So if you have trouble remembering what the M2 receptors do, so they're inhibitory receptors located on the heart, so they are going to slow the heart down. So they result in bradycardia. And then over here on your sympathetic side, you have alpha 1 receptors. And so that's your KISS, so Q-I-S-S. So your alpha 1 receptors are GQ protein coupled receptors. They're going to activate phospholipase C, which increases IP3 and DAG. That sounds familiar, right? MFM1 flashbacks, hopefully. Where do the beta 3s hang out, or is that low yield? Beta 3s, I want to say they're on your bladder for one. But I would have to look up where else. I'm kind of drawing a blank at the moment. Okay, so let's see, what was I saying? Alpha 1. Yeah, okay, so yeah, you have activation of phospholipase C, which increases IP3 and DAG. That leads to an increase in intracellular calcium. So if you have an increase in intracellular calcium, then you get contraction. So, one way to think about it is if you can remember those pathways from MFM1. So if you have increased contraction, that should give you a clue, at least somewhat, to what's going on. So in your bladder and the GI system, you're getting contraction. Yeah. And then also, so one thing I wanted to mention, okay, so why are activation of alpha 1 receptors causing a decrease in salivation? Right, but where are the alpha 1 receptors located? Are they located in the salivary ducts themselves, or are they located somewhere else, which is kind of having a downstream effect that's resulting in decreased salivation? So your alpha 1 receptors are on the vasculature. Right, Elizabeth. So vasoconstriction. So it's the vasoconstriction of the blood supply to the glands that's leading to decrease in salivation. Okay. And then, so alpha 2, remember those are GI protein coupled. So those are just reducing sympathetic outflow overall. And then your beta 1s, so 1 heart, 2 lungs. The big one to know for beta 1 is its effect on a heart rate. So activation of beta 1 receptors leads to an increase in heart rate. And then activation of beta 2 in the lungs is going to lead to bronchodilation. And how do we activate beta 2 in the lungs? Right, epinephrine released from the adrenal medulla. Right, good job. Okay, so don't forget your kissing, kick, mnemonic. Oh, here we go. You were asking about beta 3. Yeah, okay, so beta 3 is in the bladder. Did get that right. And then also, apparently, it's responsible for increased lipolysis and increased thermogenesis in skeletal muscle. But you are right. Beta 3 is more low yield than the other 4. Okay, so why is vascular tone predominantly sympathetic? And there are 2 statements here that make this correct, or that explain why, rather. Right, A is one. And then which other one would kind of complete the explanation? C. Yep, good job. Okay, so And this is kind of a point that she repeated over and over again. So the predominant tone in vascularly smooth muscle is sympathetic because you do not have postganglionic parasympathetic fibers that innervate your vasculature. So since that is the case, by default it's predominantly sympathetic tone because you get release of norepinephrine that binds to the alpha 1 receptors, resulting in vasoconstriction. Okay. So you're out hiking and then suddenly you cross paths with a bear. You run away. Where does the signal come from that allows you to increase your ventilatory capacity? All right, good job, you guys. So, and also I wanted to say, so one reason I think I did well on this test last year is anytime she verbalized a hypothetical question, like I wrote that down. So I think this is one of the ones that she said out loud. Like when she says, suppose I give you a question that's like blah, blah, blah scenario, would it be A, B, C, or D? Like literally she's giving you test questions when she says that, or she's giving you questions that are very similar to what's on the test. Okay, so I did that. I tried to do that for you. Anytime she said something like that, I made that into a practice question. But yeah, so again, release of epinephrine from adrenal medulla, activating beta 2 receptors in the lung, leading to bronchodilation. Should be on the test. Okay. Real quickly, we'll go over the baroreceptor reflex again. So all you need to know is that drugs that cause vasoconstriction are going to increase your blood pressure and lead to a reflex decrease in heart rate. And I think somebody asked me, I don't remember who it was or if you're here, is the reflex decrease in the heart rate, is that at the level of the heart, at the level of the vasculature? And yeah, so I went back to her slides and I included this to make sure it's clear. So in order to maintain homeostatic blood pressure, so to bring it back down, you get a reflex decrease in a heart rate, and that's mediated by activating the N2 receptors on the heart, and that's straight out of her slides. Okay, so just make sure that you understand that response, and if you know what's on this slide, that's more than enough. Okay. Mecamylamine, this was on the exam last year, so let's do it again. Okay, so if you give an alpha 1 agonist alone, so for example phenylephrine, you see an increase in mean arterial pressure, followed by a small decrease, but the important part is that you're going to see a decrease in heart rate. If you pre-treat with mecamylamine, so a nicotinic antagonist, before giving the phenylephrine, then you get an increase in mean arterial pressure, but you do not see any change in heart rate. So the conclusion that you draw from this is that your decrease in heart rate after giving phenylephrine, that was due to the baroreceptor reflex. So that was a reflex decrease in heart rate, and that is not a direct effect of the drug. And the reason that you know that is because when you pre-treated with mecamylamine, you didn't see any change in heart rate because mecamylamine is blocking all of your autonomic outflow pathways. So if you think of everywhere you have a nicotinic receptor, you're blocking everything by doing that. Alrighty. So before leaving your house, you take a drug that blocks adrenergic alpha and beta receptors. You get to decom, Dr. Colley stops you and says he needs to speak to you in his office. You panic, and then what manifestation of sympathetic discharge will still be apparent? So what in the sympathetic nervous system are you not blocking by blocking adrenergic alpha and betas? Right. So you still see sweating because you're not blocking those M3 receptors on the eccrine sweat glands. And then another thing that she mentioned as a WeBot, that if you give a patient a beta blocker and they're at risk for hypoglycemia, because, say, for example, they're taking insulin, then they need to know that the only symptom of hypoglycemia they will see is sweating, because those M3 receptors are not being blocked. And we're going to go over this again. Okay. So in receptor drugs. Okay. So what you need to understand from this chart is the fact that if you activate nicotinic receptors, you are activating both the sympathetic and parasympathetic nervous system. And so as a result, you need to know, at least to the extent of what's on this chart, is the dominant tone sympathetic or is the dominant tone parasympathetic? And I think that hopefully, like we've said this several times already, so the dominant tone in your vasculature is sympathetic because you're not receiving parasympathetic innervation to the M3 receptors on your vasculature. And then also the dominant tone for your sweat glands is also sympathetic, even though they're being activated by acetylcholine release, turning on the M3 receptors. And then everything else is parasympathetic. So the reason that that's important is when you come over here and talk about nicotine toxicity. So 3 drugs that you need to know here, and I would know all 3. We've already talked about mecamylamine, but you need to know that nicotine is a full agonist of nicotinic receptors, which hopefully that makes a lot of sense. And then your partial agonist is varenicline. Okay, so if someone is smoking and they decide to try the patch to try to stop, so they put the patch on, and of course, smoking is so addictive, they continue to smoke, out of habit. That can lead to nicotine toxicity. So basically, you get overstimulation of your nicotinic receptors. And early on, or in lower doses of nicotine, you're going to see the following symptoms. So you're going to see salivation, lacrimation, urination, defecation. That's with initial stimulation, sweating, nausea and vomiting, due to the fact that the dominant tone in your GI system is parasympathetic. And then you're also going to see increased blood pressure. And the reason for that is because the dominant tone in your vasculature is sympathetic. So it's sympathetic activation of alpha-1 receptors leading to vasoconstriction, leading to an increase in blood pressure. Okay, so that's early on or at low doses. At high doses, where things become really toxic, is the fact that nicotine is going to act like a polarizing, non-competitive nicotinic antagonist. And this is going to lead to death by respiratory paralysis. And does anybody know why? So why do you get respiratory paralysis? Shutting down. Right, so you're definitely all on the right track. So, yeah, receptor desensitization is part of it. And so you're activating nicotinic acetylcholine receptors that are present at the neuromuscular junction. So you're going to see contraction and then things become desensitized, so followed by paralysis. Okay. Um, that's all for nicotine toxicity. Okay, so if you have a patient who is taking varenicline, and this is one of the cases where I would know what this drug is used for. So this is used for smoking cessation. So do you guys remember this on the first exam? So if you have a partial agonist in the presence of a full agonist, it's going to act as an antagonist. So meaning if you have varenicline in the presence of nicotine, it's going to act like an antagonist. So what does this mean? So if a patient tries to smoke while taking varenicline, the drug is going to compete with the nicotinic receptors on the dopaminergic neurons, and that's going to prevent the rise of dopamine in the nucleus accumbens. So basically, you're not getting any reward by smoking. What about... Okay, hold on, I need to check my notes here. Okay, so also, so say the patient is being compliant and they're not smoking while using varenicline. So is it a complete antagonistic effect or just a decreased efficacy? Okay, so I think it would be a complete antagonistic effect. But what I was also going to say is that if you have someone who is being compliant, they're not smoking while they're taking varenicline. So if you don't have any nicotine on board, varenicline is partially stimulating some dopamine release in the nucleus accumbens, so the patient is not having the craving for the rapid rise of dopamine in the nucleus accumbens. So in that case, well, never mind. Let's just move on. Okay, so just make sure you know that if someone smokes while they're taking varenicline, then you have this situation here. A full agonist in the presence of a partial antagonist is going to act like an antagonist, and you prevent the rise of dopamine in the nucleus accumbens, so you don't get any reward. So like my understanding would be, that would be a complete antagonistic effect. Okay. 29-year female with a BMI of 24 presents to the ED with new onset hypertension, bradycardia, sweating, nausea, vomiting, and diarrhea. When you ask her what medication she's currently taking, she says she recently started wearing a patch to help her quit smoking. Which of the following likely explains her symptoms? Right, so yeah, you guys got it. So the correct answer here would be C, that she's still smoking while using a smoking cessation product. like the patch. And what tells you that is the fact that she's hypertensive, she is sweating, and then everywhere else she is salivating, lacrimating, urinating, defecating, and bradycardic, because remember, in the heart, the predominant tone is parasympathetic. So that tells you that she's experiencing nicotine toxicity. Okay. And I think I kind of beat myself to the punch here. Okay, so why is the female in the previous question hypertensive and bradycardic? I'll let one of you guys explain that. So when you're experiencing nicotine toxicity, why are you hypertensive and bradycardic? So what is the predominant tone in the vasculature?
Sympathetic.
Right, sympathetic. So you're activating what receptors?
Alpha 1.
Right, alpha 1.
And increasing
the heart rate, right? Okay. So what's the predominant tone in the heart? Sympathetic, yeah, right. Parasympathetic. And you're activating, right, M2 receptors. And your M2 receptors do what to the heart rate? Right, they decrease it. So that's why this initial response, you're going to be hypertensive and bradycardic. And then I saw somebody said reflexive. So your reflex response is going to be the decrease in blood pressure and the increase in heart rate. That's your body trying to compensate. Okay. All right, let's talk about NM receptor drugs. So the one that's, I think, a little bit easier to understand is rocuronium. So rocuronium is a paralytic, and it acts as a competitive antagonist. So if something is a competitive antagonist, can it be outcompeted? Can you outcompete a competitive antagonist? Yes. So, in order to reverse the effects of rocuronium, you are going to use acetylcholine esterase inhibitors. So, if you use an acetylcholinesterase inhibitor, are you increasing acetylcholine or decreasing acetylcholine? Increasing, right, because you're inhibiting the breakdown of acetylcholine. So you have more acetylcholine as a result. Hopefully that makes sense. So by using acetylcholine esterase inhibitors like ergophonium, neostigmine, or pyridostigmine, the phony new fire down below, then you can reverse the effects of rocuronium by outcompeting it. Okay, so the other one is succinylcholine, so also a paralytic. However, it is a depolarizing, non-competitive antagonist. So because it's depolarizing, when it binds, sodium rushes in, potassium rushes out, and succinylcholine is going to stay bound. So that's why one of your adverse effects that she had in red is hyperkalemia. So make sure you associate hyperkalemia with succinylcholine. So, so the first phase here, this is your depolarizing phase. And then the second phase is the desensitization phase. And this is because muscles are no longer responsive to acetylcholine. And that's going to result in paralysis. Okay, so question here. The graphs below show muscle twitch strength from an escalating dose of acetylcholinesterase inhibitor alone and in the presence of rocuronium and succinylcholine. Which graph is representing succinylcholine, and is it competitive or non-competitive? Right, you guys are correct. So succinylcholine is here on the right, and it is a non-competitive antagonist. So if you look at the graph, so if you know that succinylcholine is non-competitive and you're trying to decide, is it graph A or is it graph B, what are you looking for? Like, how did you guys decide that this graph is succinylcholine? Right, so Dominic is correct. So succinylcholine, since it's a non-competitive antagonist, is going to decrease your Emax. So if you go to this slide, so this is out of first aid. So if you have a non-competitive antagonist in the presence of a full agonist, it's going to affect your Emax, so a decrease in Emax. If you have a competitive antagonist like rocuronium, it's affecting your potency. So by shifting to the right, you get a decrease in potency. So yeah, you guys are correct. So decrease in efficacy or decrease in Emax versus a decrease in potency. And remember, if the EC50 is greater, that means that it is less potent. So this is kind of where, the stuff from the first block, you can start applying it. Okay. So direct muscarinics. Okay, so use of an acetylcholine esterase inhibitor or activation of nicotinic receptors will result in hypertension. Why? Can somebody explain why? So why would using an acetylcholine esterase inhibitor result in hypertension and not hypotension? Right, so you get an increase of acetylcholine, right? You get alpha 1 stimulation, so is that sympathetic or parasympathetic? Right, so I see a good answer there. So because the predominant tone in the vasculature is sympathetic, right? So remember, you do not have any postganglionic parasympathetic fibers innervating those M3 receptors on vascular smooth muscle. So the predominant tone in your vasculature is going to be sympathetic. Okay, and then, same concept with the activation of nicotinic receptors. Okay, so the initial response to the use of an acetylcholine esterase inhibitor will produce which of the following effects? tachycardia, constipation, vasoconstriction, or hypotension? Right, vasoconstriction. Okay, let's see, question. So can we figure with anything affecting acetylcholine, it will just accentuate their dominant tones? Initially, yeah, initially. So remember when we talked about nicotine toxicity, your initial response is accentuating the dominant tones, but then, things like your like reflex arc kick in and things start to flip. So yeah, that's going to be the initial response, is to accentuate dominant tone. Okay, so yes, correct answer here is C, vasoconstriction. Why isn't it tachycardia? Because the beta 1. Okay, yeah. So remember, what is the dominant tone in the heart? Is it sympathetic or parasympathetic? Right? It's parasympathetic. So if you increase acetylcholine everywhere acetylcholine is, then the effect is going to be activation of the M2 receptors, because that's the dominant tone, which which decreases the heart rate, leads to bradycardia. Yeah, but that's a really good question, though. Okay. Moving on. Okay, so our M receptor agonists. Your high yield on this slide is going to be pilocarpine. So and also the fact that pilocarpine can penetrate the CNS. So with pilocarpine, because it has CAR in it, you can remember that you drive the CAR in the brain. And then the two that are muscarinic agonists that can penetrate the CNS are bethanyl and methacholine. So chol is below the ground, or like below the head of the CNS. But the big thing to know about pilocarpine, other than it treating glaucoma, would be the fact that it can cause hypotension. And you guys were asking in the beginning, what's the point of the M3 receptors, and the fact that they're activated exogenously. So this is where we get to that point. So if you give someone pilocarpine, why can that result in hypotension? Right, because in this case, pilocarpine can directly activate M3 on the smooth muscle of the vasculature. So in that case, you would get hypotension. Okay. So here we go. High yield point here. Okay, so what change do we see in blood pressure when administering a direct acting muscarinic agonist versus a direct acting nicotinic agonist? So what's the difference between pilocarpine versus a nicotinic agonist, like nicotine, as far as your blood pressure goes? So if we give pilocarpine, what do we see? Hypotension. Because why? Right, you're activating M3, which leads to, what do you get before you get the hypotension? Vasoconstriction or vasodilation? Right, vasodilation. Right, okay, so if you give someone a direct acting nicotinic agonist, what happens? Right, hypertension. So we went over that one. Yeah, so make sure you know the difference there. All right. So let's talk about our acetylcholine esterase inhibitors. Um, let's jump to the bottom first here. Okay, so your acetylcholinesterase inhibitors that cannot penetrate the CNS, that's your phony new fire down below. So again, with the remember, like coal was in the ground, phony new fire down below, um, are not penetrating the CNS. So examples of these are going to be edrophonium, neostigmine, and pyridostigmine. And I'm pretty sure she said edrophonium is off the market now, and I think I read that too. So you probably don't need to worry about that one. The two that you're going to see are neostigmine and pyridostigmine. So pyridostigmine is what's going to be used to treat myasthenia gravis. And this is one of those where I would know the use just because it's important to understand this concept here, which is distinguishing between a myasthenic crisis and a cholinergic crisis. So, a myasthenic crisis is worsening of the disease itself, so worsening of myasthenia gravis. If you have a cholinergic crisis, you have worsening of weakness when the drug is in excess due to improvement of the disease. So suddenly the disease has improved, you're still giving the same dose of pyridostigmine, and now you have too much acetylcholine, which is leading to receptor desensitization and the things that come along with that. Okay. So the other one to know here is that, so acetylcholinesterase inhibitors, which don't let this confuse you. This has nothing to do with myasthenia gravis, but acetylcholinesterase inhibitors are used to reverse paralytic effects of neuromuscular antagonists, so like rocuronium. Yeah, so Amy, I have a couple practice. I don't want to answer that because I have a couple practice questions right after this slide that go over that. Yeah, so as far as I know, so I don't know the answer to that, to be honest. I guess neostigmine is the one that's most commonly used. Are there other ones you could use? I don't know. Not that we've ever learned. Okay, so real quickly before we move on. Yeah, neostigmine, that's true. It is used because it's short acting. But as far as like, is there anything else you can use to determine if it's myasthenic versus cholinergic? I don't know. I think neostigmine is definitely the one that's like most commonly used. Okay, so your organophosphates. So I wouldn't worry too much about Sarantabin or Soman. She acted like that was pretty low yield for her. But I would be aware of malathion. So malathion treats things like body lice and scabies. And so if you have something like malathion toxicity, the antidote to this is pralidoxime. So pralidoxime is going to prevent aging or the permanent inhibition of acetylcholine esterase. So, and if you think about the nerve gases, you can probably get this right. So if you have permanent inhibition of acetylcholine esterase, you cannot break acetylcholine down. How do you think you're going to die? So, and think about nerve gases. You've probably heard this before. Someone who's exposed to nerve gases, right? Respiratory arrest, or like more specifically, like respiratory, yes, yeah, spastic paralysis of the diaphragm. Yeah, that's what I was looking for. So, in order to prevent diaphragmatic paralysis, and you stop breathing, you're going to give pralidoxime. So that's going to prevent aging, which is the permanent inhibition of acetylcholinesterase. So if you prevent that from happening, then of course you have a better chance of saving the person. Okay, so a couple questions here about myasthenia gravis. Okay, so you have a 30-year-old female patient treated for myasthenia gravis with pyridostigmine. She complains of fatigue, weakness, ptosis, and diplopia, especially at the end of the day. You decide to give the patient a dose of neostigmine, and her symptoms get better. So what is the most appropriate next step in the management of her disease? Right, so you're going to increase the dose of her acetylcholinesterase inhibitor because things got better. Okay, and then would she be having a myasthenic crisis or a cholinergic crisis? So if she has more acetylcholine and things get better, is that myasthenic or cholinergic? Right, she's having a myasthenic crisis in that case. Okay, so same patient. The only difference is you give her a dose of neostigmine and her symptoms get worse. Now what are you going to do? Right, so you're going to decrease the dose of her acetylcholinesterase inhibitor. And is she having a myasthenic or a cholinergic crisis? Right, she's having a cholinergic crisis because now she has plenty of acetylcholine, but things are getting worse. So if she's having a cholinergic crisis, does that mean that her disease process has it likely improved or has it gotten worse? So if you're having a cholinergic crisis, right, that means that her myasthenia gravis has probably improved. And now her acetylcholinesterase inhibitor, the dose is too high. Okay. Catch up in my notes here. Okay, so cholinergic toxicity. So when you're talking about sludges or muscarinic agonists, you're going to see, of course, salivation, lacrimation, urination, defecation, GI complaints, emesis, sweating, bronchospasm, bradycardia, and meiosis, but you're not going to see muscle fasciculations. So why would that be? So in muscarinic toxicity, you see these things, but not this. Why is that? Right, so you don't have any muscarinic receptors at the neuromuscular junction. So when you increase acetylcholine everywhere acetylcholine is, remember one place acetylcholine is at the neuromuscular junction. So you're going to have muscle fasciculations. That's all for this slide. And then also, of course, we've said this 100 times, so when you increase acetylcholine everywhere acetylcholine is, you're going to get an increase in blood pressure because the predominant tone in your vasculature is sympathetic. So activation of your alpha-1 receptors, vasoconstriction, and increase in blood pressure. Okay. And this is pretty much out of Dr. Babos' slides. So you have a 50-year-old female exposed to an unknown toxin with mild confusion, GI cramping, emesis, use of excess accessory respiratory muscles, expiratory wheeze, bronchorrhea, and muscle fasciculation. So that's your first big clue. Her pupils are equal, round, pinpoint, and non-reactive to light or accommodation. She has watery eyes, salariae, fecal and urinary incontinence, and she's diaphoretic with cool and pale skin. She's also hypertensive. So, what is the mechanism of action of the toxin she was most likely exposed to? So I just changed the question slightly. So instead of asking you for the drug, I'm asking you for its mechanism of action. Right, A. So that's the correct answer. So what do you think that we've talked about? That what was she likely exposed to? What's an example of an acetylcholinesterase inhibitor that she could have been exposed to? That would give you these. Right, an organophosphate, so like Nergas or malathion. Yeah, good job. Okay, so you were very confident in your clinical skills and you determined that the patient was exposed to malathion and you treat her with pralidoxine and atropine, which adverse effect of organophosphate poison will not be reversed by atropine. So what? Oh, so let's think about this. So what is atropine? Or what is the mechanism of action of atropine? What receptors? What receptors is it blocking? Right, it's a muscarinic blocker. So you're blocking muscarinic receptors. Do you get sweating? Yes or no? Right. Yes, I see the correct answer now. Okay. So the correct answer here is C. So if you're giving a muscarinic blocker, um, you're going to get rid of the sweating. So the one thing that you're not going to get rid of is the hypertension. Does that make sense? That's because the alpha 1 receptors are not blocked by a drug that blocks muscarinic receptors. So vasoconstriction and hypertension are still going to happen. So remember salivation, lacrimotion, urination, defecation. Those are all muscarinic effects. So if you give an anti-muscarinic, also bradycardia, you're blocking bradycardia, you're blocking salivation, you're blocking sweating. Does that make sense? Okay, I hope that makes sense. That was a tough one. Okay. Now, you have a medical student following you in the ED, and they say that you made a mistake, and the patient in the previous question was likely poisoning by Amanita muscarina. And believe it or not, these mushroom names are actually in first aid. So you correct the medical student by explaining that it is unlikely that the patient was poisoned by Amanita muscarina due to the presence of what two symptoms? So first of all, this mushroom, it's going to cause, if the patient was poisoned by this mushroom, what type of toxicity would that cause? Like what receptors would you be activating? Look at, right, muscarinic, okay? So you know that the patient was not poisoned by Amanita muscarina because there's two symptoms they have here that muscarinic poisoning would not lead to, right? Yep, so most of you got it here. So hypertension and muscle. Yeah, it's okay. Yeah, this is really tough. My gosh, it's like mental gymnastics, me trying to explain it. Like, okay. Um, so I got this idea for that question from this chart here. Okay, so if you have cholinergic toxicity, so remember we went over that, um, you're going to see muscle fasciculations and also an increase in blood pressure. If you have a muscarinic agonist, you don't get those fasciculations because remember at the neuromuscular junction there are not muscarinic receptors. And then also if you're giving an exogenous substance that activates your M receptors, that's one way you can get hypotension. Okay, so yeah, that's tough. Alrighty. So the mushroom was a muscarinic agonist. Okay, so what condition are you going to treat with atropine? And I believe this is one of those that she kind of said out loud. Like, hypothetically, if I was to give you this question, right. So the correct answer, yeah, not glaucoma. I can tell you that. Good. That's the most high yield. That's probably the question you're gonna get. Actually, is about glaucoma. So if you know that, you're on the right track. Okay. So treating asthma bronchoconstriction with atropine. Okay. So why would you not treat glaucoma with atropine? What will atropine cause? It causes mydriasis, right, which is bad. In angle closure glaucoma, yeah, because it causes an increase in intraocular pressure, right? That's correct. So basically, it's a medical emergency. So yeah, just remember, mydriasis is bad in angle closure glaucoma. Okay, so why would atropine not treat xerostomia? So, what does this word mean to begin with? Right, dry mouth. So, why would atropine not work for that? Right, because it causes dry mouth, so it's just going to make things worse, right? Okay, so why would you not give atropine to treat hypertension? So, why would you not give a muscarinic antagonist to treat hypertension? What did we say about the M receptors on smooth muscle vasculature? Right, they're not innervated. Correct. Okay. So a way to remember the side effects of antimuscarinics are what they call the toxidrome of the five-old auntie. So hot as a hare, red as a bee, dry as a bone, mad as a hatter, blind as a bat, and full as a flask. Um, so if you think about all of those, so yeah, starting at the bottom, If you are blocking M receptors, you're going to get urinary retention. If you're blocking M receptors instead of meiosis, you're going to get mydriasis. If you're blocking M receptors, you get confusion and delirium instead of improvement in cognition. You block M receptors on your eccrine sweat glands, you're not going to sweat. And then your red as a beet and hot as a hare are also related to sweating. So anhidrosis, if you have the absence of sweating, this can really lead to peripheral vasodilation for heat dissipation. So you get red skin, and then you also get an increase in temperature if you're not able to sweat. So you're not able to get rid of that heat. Okay. I believe in her slides. So, like I said, for the most part, what the drug's used for is not near as important as its mechanism of action and how it's working. But I would say this slide is a few exceptions because she did have some of the uses in red. So one of those is scopolamine. So a lot of times people before going on trips like cruises will get what they call like a scopolamine patch. And this is going to block your M3 receptors in the vestibular apparatus to decrease motion sickness and vertigo. So I would know that one. And then also benztropine. It's used to treat tremor and Parkinson's disease. And I think she talks more about that in her dopamine lecture. One big one is tropicamide. So tropicamide is used if both mydriasis and cycloplegia are desired. So this would be bad for somebody with glaucoma because, of course, she said a lot. Mydriasis can cause critical elevations in intraocular pressure, so a medical emergency. So basically, if somebody has glaucoma, tropicamide would definitely be contraindicated. I wouldn't worry too much about Botox. Okay, and then again, anti-muscarinic contraindications. The one you need to know is glaucoma. Do not give an anti-muscarinic to somebody with glaucoma because this can lead to mydriasis, which may cause a critical elevation in intraocular pressure. All right, so that should be a WeBot. It was last year at least. Okay. Question here, a 21-year-old female patient is requesting a drug to help with motion sickness on her upcoming spring break cruise. Which drug should you prescribe her? Right, good job, scopolamine. And I have no idea what the question was like last year, but I do remember scopolamine being on the exam. Okay. I only added this in to point out this enzyme right here. So you're not going to be tested on any biochem. The only reason I bothered to do this is because this was an exam question more than once in second year. So I figure the more times you see it, hopefully the more likely you are to remember. So phenethylamine N-methyltransferase converts norepinephrine to epinephrine. And in what tissue, organ, whatever, where are you most likely to see this enzyme? Right, the adrenal medulla. So remember, your adrenal medulla is releasing epinephrine, so it makes sense that phenethylamine and methyltransferase would be found there. So that's just kind of like a high yield ding ding second year like boards kind of question. Okay. So catecholamines in the cardiovascular system. Okay, so I think that you guys had all of this stuff in CardioPhys, and I told some people that farm helped me learn physiology better than physiology ever did. And that's because, this stuff comes back up and, you apply this knowledge with how you use the drugs. So thankfully, I think the farm department does a really good job of kind of reteaching a lot of the physiology on top of the farm. Okay, so just kind of to review, your mean arterial pressure, that's equal to the cardiac output times the peripheral resistance. So if you stimulate your alpha 1 receptors, you get an increase in resistance, which is going to eventually lead to an increase in blood pressure due to that increase in mean arterial pressure. And then, of course, with that increase in blood pressure comes the reflex decrease in heart rate due to the baroreceptor reflex. The next equation, cardiac output equals stroke volume times heart rate. So if you stimulate beta 1 receptors, you get an increase in heart rate and subsequent increase in cardiac output. So alpha 1 stimulation causes greater increase in mean arterial pressure than beta 1 because resistance is exponential, whereas beta 1 stimulation is a direct relationship. So what this means, resistance is exponential. Remember, peripheral resistance, and I should have included this in here, but it's like 1 over the radius to the 4th power. I think somebody can correct me if that's wrong. So that makes it an exponential relationship affecting the mean arterial pressure versus beta 1 stimulation, which is a direct relationship. So if you stimulate beta 1 receptors, you get an increase in heart rate, which leads to an increase in cardiac output. If you get an increase in cardiac output, you're going to get an increase in mean arterial pressure, leading to an increase in blood pressure. Okay, and then the final one, stroke volume is equal to contractility multiplied by the venous return. So if you stimulate beta 1 receptors, you get an increase in the contractile force and expansion of volume. Okay, so here's my disclaimer on like the next 3 slides. So this is really difficult to explain and something that I struggled with last year. So I'm going to give it my best attempt. But if you have questions that I can't answer, which is a possibility, I would schedule a meeting with Dr. Babos because she loves to talk to students and she could probably do a much better job than I can explaining this. But that being said, I will try to be even better at this, next time we meet, and hopefully, I'm hoping that I can find some like already made practice questions in some of the textbooks relating to this, because there were 2 of these, like she said, and she said it's going to be like that again this year. There are 2 of these on the exam. So you need to, understand this stuff because that's worth 2 questions. Okay. So to explain the tracings, I pulled this out of the Kaplan lecture notes. Okay, so the zigzag up and down. So increases are seen as deflections of the tracing upward. So if you have a deflection upward, like this is going down, so that's a decrease in blood pressure. But if you have a deflection of the tracing upward, that represents an increase in blood pressure. If it deflects downward, that's a decrease in blood pressure. Okay, if the little jagged lines get closer together, that represents an increase in heart rate. So if they appear closer together, that means there's an increase in heart rate. If the lines are farther apart, this represents a decrease in heart rate. Okay. Yeah, and then here they give you an example. Okay, so this is just random drug X. So you've changed the baseline parameters by decreasing mean arterial or mean blood pressure, so that's your downward deflection, and then increasing heart rate. So the tracing gets tighter, like the zigzag lines get closer together. That represents an increase in heart rate. Okay. So if we look at the tracings, so if you give phenylephrine, so an alpha-1 agonist, you're going to see an increase in blood pressure. And if you look at the tracing, so you see that upward deflection. And of course, it's giving you the numbers here, which I'm 99% sure that's not going to be the case on the exam. So don't depend on those numbers. You need to know how to read the tracing. So increase in blood pressure is the upward deflection. And then you're seeing a decrease in heart rate. So the zigzags are getting further apart. And I know you can't tell that here. Like the heart rate is really hard to tell based on the tracing. But they will give you a tracing that is less condensed to where you can see the change in heart rate. Hopefully that makes sense. But you'll be able to tell, is what I'm saying. Okay, and then, okay, in the second example, they're giving epinephrine. So again, upward deflection. You see an increase in blood pressure, and you can see that here with the numbers that are given. And then you're also going to see an increase in heart rate. So the tracing, the lines are closer together. Should we be able to tell what receptor it is based on the tracing? I don't know if they'll make the question, how the question be phrased. The question more likely will be what drug or what substance was most likely given based on the tracing. So if they showed you this tracing and they said, was the person given, phenylephrine, were they given dopamine, etc., then by looking at the tracing and knowing the effect, then you should be able to determine that. Yeah, so knowing that, yeah, exactly. So knowing the effect of the drugs is really the most important thing. Okay, so I would definitely know this slide. This should help you. Okay, so dopamine, the D1 receptor is going to be the predominant effect. So dopamine in low doses is resulting in a decrease in blood pressure due to vasodilation at the, renal arterial beds. Okay, and then at moderate doses, you're getting stimulation of D1 and beta 1, so decrease in blood pressure and increase in heart rate. And then at high doses, alpha 1 is predominating over D1. So if you have activation of alpha 1, you're going to see increase in blood pressure and increase in heart rate. And then with epinephrine, the predominant effect is going to be beta 2, so decrease in blood pressure and increase in heart rate until it reaches high doses, which is where alpha 1 is going to take over, and you see increase in blood pressure and increase in heart rate. And then here with norepinephrine, you want to know that the dominant effect is the beta 1 receptor, so increase in blood pressure and increase in heart rate. And like I said, I'll try, and I think, I don't know if she has already, but she will put out some practice questions with tracings like this on it. So I think when we're able to do those questions, that this should hopefully make more sense. But I will say this is probably the hardest question on the exam, or at least it was for me getting these correct. So this may take a little bit of time. Okay, so this was in her lecture notes. So the graph on the left is phenylephrine alone. On the right, the patient was pre-treated with a drug. What drug was given on the right prior to phenylephrine. So, right. So on the right, the patient was pre-treated with mecamylamine. And how do you know that? Right, so there's no reflex change in heart rate. Yeah, and the heart rate is the same. That's correct. Okay. Which of the following can be given subcutaneously? Right, epinephrine, and that's because epinephrine stimulates the beta 2 receptors, which prevents tissue necrosis and causes bronchodilation. So, this should be a Weebot, but if you just think of an EpiPen, you should get this question right. So, everyone I think has heard of an EpiPen. So, epinephrine can be given subcutaneously. Okay. Catch up here with my notes. Okay, so direct adrenergic agonist. So I would know these drugs, of course, and I would also know, are they preferentially activating alpha 1, alpha 2, or beta 1, or beta 2? So phenylephrine is activating alpha 1, and one of the important things she said to know is that phenylephrine causes mydriasis, but does not cause cycloplegia. Okay, and then also, let's see. Okay, so I would know that dobutamine is beta 1 preferentially. So it's going to significantly increase cardiac output due to the increase in heart rate. So you're going to increase heart rate and then increase cardiac output. And then, actually, now that I think about it, I put a star here. Okay, so the ding ding here is albuterol. She said to make sure to know this one, and then it activates some beta 2 to treat bronchospasm. So you're activating your beta 2 receptors, resulting in bronchodilation. Okay, so which neuronal or neurohumoral tissue can generate a signal that can reduce afterload? So I don't remember, this was either one of the polling ones or again one of the ones she said out loud. Okay, so the correct answer here. So the correct answer is C, and that's because beta 2 receptors that are located on the vascular smooth muscle, those are stimulated by epinephrine, and that can cause vasodilation, which will reduce afterload and the resistance to flow. So don't forget about your beta 2 receptors on your smooth muscle vasculature. So remember, you have your alpha 1 receptors, which are innervated, and then beta 2, which are not, but they do receive epinephrine from the adrenal medulla. Okay. So the big one to know from this slide is going to be phenelzine. So she definitely ding-ding this one. So basically, last year the question was super obvious. You see a patient who suddenly has a hypertensive crisis after eating cheese pizza. What drug are they likely taking? So that's going to be a MAOA inhibitor like phenelzine. So think, cheese pizza on phenelzine, you get a hypertensive crisis. And as far as, so I got a lot of questions that were like, do I really have to know every drug or can I just focus on the red, yada yada. So like on this slide, if it's not something, that she ding dinged or was in red, but it's on the drugs to know list, I would at minimum know the drug's mechanism of action. And that should help you because, when you have a question and then for drugs, if you know the drug's mechanism of action, you're going to have a lot easier time eliminating the wrong answer. So at least know that much if it's not something that she spent a lot of time on. Okay. We're almost done. Okay, so your adrenergic antagonist. Okay, so high yield to know here is the fact that alpha 1 antagonists, for example, doxazosin and tamsulosin, can lead to hypotension, reflex tachycardia, and what's known as first dose syncope. So if the question is something like, you have this male patient who is being treated for hypertension and he also has BPH and he suddenly presents to the ED with a syncopal episode, what is he most likely taking? The answer to that question is going to be doxazosin. And so she ding this one. So definitely know doxazosin, and then I would know that tamsulosin is an alpha 1 antagonist. And you can also see that first dose syncope like you can with doxazosin. Okay, so beta blockers. You don't need to know really when to use a beta blocker or which one to use or in what patient population. None of that is really important. I think it was this lecture where she had a lot of extra stuff, but I did see she did write somewhere, don't worry about the uses or don't worry about all of this. So what you do need to know is, at least right now, is that for your beta blockers, so your non-selective beta blockers are going to start with N through Z. Your selective beta blockers are going to start with A through M. And one important side effect that you can see from the use of beta blockers is what's known as decreased hypoglycemia awareness. So if you have, your classic diabetic hypertensive patient who's on a beta blocker for their hypertension, and then they're also taking insulin for their diabetes, you need to make sure that person knows that the only sign of hypoglycemia that they may notice is sweating. So if somebody takes way too much insulin, that can kill a person. So if they're not aware of that, that's obviously a huge concern. So you need to make sure you know that sweating can be a sign of, or it's the only sign that you'll see in hypoglycemia if a patient is on a beta blocker and being treated for diabetes. Okay. So here, I would just know that these drugs fall under the category of non-selective or combined alpha and beta block. I wouldn't worry so much about, the uses here. Just mainly looking for the mechanism of action. Okay, so a couple more practice questions. All right, so a 65-year-old male patient presents to the ER following a syncopal episode. He recently started medication to treat hypertension and urinary outflow obstruction. Which medication is likely responsible for his syncopal episode? And I'm sorry, I just realized I may have put 2 correct answers on here. Which was the one that she ding though? Yeah, so doxazosin. Okay. This one is tougher than what you're going to see on the exam, but I think you can get it right. I saw this one on like a USMLE practice question site. Okay, so a 70-year-old male patient with a history of dementia and hypertension presents to the ED with profound bradycardia, altered mental status, and profuse sweating. Hint, hint. You check his labs and his glucose is 45, so aka it's low. Which of the following is the most appropriate therapy at this time? Right, so the correct answer here is C. So he's hypoglycemic. What drug likely caused this? What drug is he taking? Or what drug is he taking that made this less obvious? Right, so he was likely on a beta blocker and probably diabetic. Okay. Yeah, so don't let this question, right, like propranolol. Yeah, that would be a good example. Don't worry about these others. I don't think you've talked about them. So flumazenil, right? All of them have the potential to do it, but your non-selective ones are more likely. So what I was going to say is, don't worry about these other 3 options. So flumazenil is the antidote for benzo overdose, and then sodium bicarb is the antidote for overdose on tricyclic antidepressants. But she would never give you stuff as answer choices that you haven't seen before, if that makes sense. All right, finally made it to the end. Yeah, you're welcome. And I will upload my version, and I also have a whole bunch of notes in my version. So if you look in the at the bottom where the notes are, you'll see a bunch of explanations and stuff that might help if you look at this version that I'm about to upload. Yeah, I will post this on YouTube as well. Yeah, Cody, that's exactly correct. So, glucagon, you're giving glucagon because he's hypoglycemic. All right, I hope you guys have a good week. I'll see you on Wednesday. And Wednesday, I will go over the dopamine lecture. The only reason I didn't do that is I noticed that she didn't finish on Blackboard. So I'm kind of waiting for her. I'll cover that on Wednesday.